So, hello everyone, and good morning, afternoon, evening to wherever you are. And first of all, I would like to thank you all for attending this specific session, which is on Asia. And first of all, I'd like to introduce myself. My name is Jay Das. I'm an assistant professor at the Division of Women and Child Health at Aga Khan University, Karachi. And we would start this session by a presentation from Dr. Khawaja Masuood Ahmed, who is the National Coordinator for Nutrition and Nutrition Fortification Alliance, which is based at the Ministry of National Health Services, Regulation and Coordination, Islamabad. And he would be taking us through the case study of Pakistan. What are the enablers and barriers for scaling up wasting services? So over to you, Dr. Khawaja.
Thank you, Jay. Good morning, good afternoon, good evening, everyone. I'll be taking you to some of the enablers and barriers to scaling up wasting services in Pakistan. First of all, before going to the enablers and barriers and how we have progressed, I will tell you to some of the statistics about wasting in Pakistan. Unfortunately, undernutrition among children is still a public health problem in Pakistan for the last few decades. And in spite of quite rigorous efforts, we have not been able to make a lot of progress in it. And still about 74 children die below the age of 5 years out of 1,000 live births. Rates of wasting have increased during the past 2 decades, as you can see in the slide. It was 13.1% in 2001 and it has increased to 17.7% in 2018, a national nutrition survey conducted 2 years ago. Unfortunately, things are not improving in spite of the fact that Pakistan was among the first countries who adopted SDGs in the national planning for nutrition and health. However, the progress has been very slow, and as you can also see, stunting, there has been slight improvement in stunting during the last 7 to 8 years. Underweight children have improved, but wasting is still high. In Pakistan, we have 4 provinces and 4 regions. The 4th region has now merged with a province, but these are the provincial figures. And apart from Punjab and ICT and GB, you can see that things are not very good. Sindh has the highest prevalence of wasting, while this is followed by newly merged districts in Khyber Pakhtunkhwa. If we talk about numbers, about 5.5 million children are wasted in Pakistan, and the prevalence between urban and rural is not much different as revealed by NNS 2018. This slide shows a breakdown about severe and moderate wasting, and very strangely, in some of the provinces, severe wasting is higher than the moderate wasting. The reason being, we do not have programs scaled up in the entire country or in major part of the country. That is why children who are suffering from MAM, they progress to SAM before they are caught up for the treatment. Coming to numbers, 2.5 million children are suffering from SAM and 3 million from MAM. Now we'll go to some of the successes during the last couple of decades in our wasting services in Pakistan. Pakistan started implementation of CMAM after 2005 emergency, which was earthquake in the northern areas of Pakistan. And from 2005 to 2011, CMAM was implemented as an emergency response to the natural disasters. And it was mainly donor funded and it only covered emergency areas. From 2012 to 2019, government of Pakistan and the provincial governments tried to scale up CMAM, but unfortunately till 2018 coverage was not more than 5%. In 2018, government of Pakistan adopted the DCP3 approach and a minimum essential nutrition package was developed that included CMAM services as a part of the service delivery package for health. Wasting management has recently also been integrated into the National Nutrition Program Project Concept Note, which is for the next 5 years, for 2021 to 26, and this reflects a new understanding leading to the embedding of wasting prevention and treatment at the heart of stunting reduction strategies. Drive to mainstream CMAM services into primary healthcare, in spite of the fact that they started in 2018. But again, due to many barriers, we have not progressed a lot. Let me take you through some of the enablers first, and then we will focus on the barriers. The first enabler is important strategic and guiding framework. Pakistan developed CMAM guidelines for the first time in 2010, and this really showed a political commitment towards tackling wasting in Pakistan. After that, during the period when CMAM was being adopted in the normal health service delivery or nutrition service deliveries, CMAM was integrated into the provincial level plans or provincial nutrition programs. Inclusion of wasting treatment and prevention within the Pakistan multi-sectoral nutrition strategy in 2018 was another step in developing a policy framework for addressing wasting. And then, as I mentioned in the previous slide, wasting treatment has been included in the large-scale national nutrition program in pipeline, and this would be targeting the high-burden districts of the country with around 35% of population. It means that we would be having higher coverage of treatment services because these districts have the highest burden. Second enabler for management of wasting in Pakistan is utilization of lady health workers. Initially, when Pakistan started CMAM interventions, it was started as a parallel program, and there were nutrition assistants who were hired at the health facility to take care of the CMAM services. But very recently, as we are shifting towards the integration of CMAM into the primary healthcare and normal nutrition service delivery or health service delivery in Pakistan, we have started utilizing the lady health workers. These are the community health workers based in rural and suburban areas of the country, and this is a strength of Pakistan. This army of more than 92,000 health workers in the country, it has changed the health service delivery in Pakistan. This approach again has been integrated into the National Nutrition Program to increase the coverage of services, which has not reached till now more than 10%. The third very important step was the local production of lipid-based specialized nutrient supplements, RUTF and RUSF. These are used for the implementation of CMAM programming. RUSF are produced in Pakistan for the last decade with the technical support of World Food Programme, and these have a modified composition based that suits to the Pakistani culture. And one important development is that government of Pakistan has exempted taxes and import duties on the import of raw material that is used for the local production of these RUSF. This have definitely reduced the cost of RUSF and would definitely improve the coverage or our efforts to scale up. Similar efforts are now being made for RUTF because in spite of the local production of RUTF for the last couple of years, still most of the raw material is imported, and there is no cost improvement or cost decrease because of high import duties on the import of raw material. Next step would be, or we have started working on that, is the inclusion of these RUTF, RUSF, as well as the multi-micronutrient tablets in the essential drug list of Pakistan. Integration of nutrition indicators in the district health information system 2 is another enabler. The work has been initiated for the last year or so, and we are working closely with the our information component in the ministry to integrate all the nutrition indicators, including CMAM, into the DHIS2. A cost-effective analysis for proposed minimum essential nutrition package has already been carried out, and nutrition wing of the Ministry of National Health Services is developing a nutrition investment case for each of the 4 provinces using World Bank Optima Nutrition tool. And the result of this process will be used to inform advocacy for allocation of necessary resources, which is one of the issue hindering the scale up of CMAM or wasting management services in the country. Now we'll talk about some of the barriers for scale up of these wasting services. As I mentioned that till 2018, the coverage was not more than 5% for wasting services, and during the last year or so, it has increased slightly and reached 10%. And this is basically due to the incorporation of management of wasting in the stunting prevention programming in the country. The barriers include historical omission of wasting treatment in the government strategies, and it was usually taken as an emergency short-term problem. Previously, vertical staff was hired to manage children for wasting. There was lack of supply chain for nutrition commodities, and there was no process of monitoring the indicators related to CMAM, because these indicators were missing in the normal reporting system. One very important barrier is the high cost of treatment, and this high cost is mainly responsible for decrease in scale up, or as a barrier of scale up of these wasting services in the country. And further to that, we have limited resource allocation by the provinces, especially for wasting management. Secondly, discontinuity of regular CMAM activities have been on and off going on due to shift of attention to some of the other emergencies in the country. Previously, CMAM management or CMAM was not integrated in the primary healthcare services, and the reliance was mainly on the short-term external funding or donor funding and partner funding, which is still going on. And until and unless the resource allocation is carried out by the government, provincial and the federal itself, we will not be able to scale up CMAM in the country. What actions are being carried out nowadays to address these barriers? Wasting management, as I mentioned earlier, has been made integral part of all these strategies for nutrition service delivery and also for stunting prevention. Capacity building of the staff has been carried out, and it is an ongoing process which is going on. We have taken the support of partners, WFP and UNICEF, for supply chain management. Advocacy is going on with the provinces to allocate resources for management of wasting, which is definitely a big task at the moment. At the highest nutrition coordination forum, which is the National Nutrition Coordination Council under the chair of Prime Minister, and the PM directed provinces to consider malnutrition as a human right issue in the development agenda of the country. And since then, a lot of movement is going on in the provinces as well as at the federal level for allocation of resources for overall nutrition activities, and also specifically focusing on management of wasting, which definitely we have more than 5 million children at present. Discussion and negotiations are on with the partners and donors to further support and contribute to the government efforts to address wasting management. There is definitely commitment at the government level. Mainstreaming wasting management in primary healthcare process has already been initiated through DCP3 as well as universal health coverage packaging in Pakistan, and the federal national nutrition program PC1 is a good example. Pakistan is also one of the few early countries who have started adoption of global action plan for child wasting, a framework for action. The process has been initiated. We are in the process of revising the multi-sectoral nutrition strategy with a more focus on child wasting, and then followed by development of national action plan for nutrition. Advocacy at all level is going on to allocate more resources for wasting management in all the nutrition programming, and capacity building of all healthcare workers at all levels on wasting management has been made a part of the nutrition program and has already initiated in all the provinces. Thank you very much.
Very insightful on Pakistan and giving us certain achieved and what's the future like. Encourage all those that side and so I would like to start by asking that you mentioned that CMAM has been the part for since 2005 in Pakistan, but the coverage has been low. So, major bottlenecks in improving the coverage of CMAM, and what different strategies the government is thinking to fill coverage?
Actually, CMAM has been taken as the emergency programming from the very beginning since 2005. We had a lot of natural disasters from 2005 to 2012, including earthquake and then floods, and most of the focus was on those areas in managing that. After 2012 and after devolution, the focus definitely shifted towards incorporating CMAM as the normal or as part of service delivery, but due to the high cost and limited resources, we have not been able to improve much, and still the coverage is not more than 10%. But for the last few years, CMAM has been included in among all the strategies, nutrition strategies, or the stunting prevention strategies, which has paved the way for a scale up of CMAM interventions throughout the country. And federal government is committed to allocate resources, and the same has been requested to the provinces, so that we will be covering through federal support the 35% area of the country. So for the remaining area, provincial governments have to come up, plus other partners and donors, they can also support. Jay?
Be asking 21 to 25 of RAM.
Excuse me, I could not hear the question, Jay.
Okay, so the question was by Sergeant Shafiq, who's that will the federal PC1 2021 to be in continuation of the ongoing nutrition program AAP in Sindh?
No, I mean, we have selected the high burden districts, and when the federal PC1 is implemented in the provinces in high burden districts, the districts which are being overlapped under AAP, they would be shifted. And I mean, the AAP would shift the districts to the uncovered districts. That has been the agreement with all the provinces, because in all the provinces, some level of nutrition programming is going on. And we have an agreement with them that whenever the federal PC1 would come up with, which would be implemented in highest burden districts, the provincial programming would be shifted to the other districts which would not be covered by the federal PC1.
Okay, great. So there's another question, and it's a very, very important question that has been asked, is that when we talk about CMAM, is the government also looking on elevating the risk factors which contribute to this wasting burden, and what has been done specifically to look at the impact on in utero and the early phase of life, which is the initial 6 months of life? So how role in the practice of in the later childhood, and what specific
I'm sorry, Jay, I could not hear the complete question, but still, based upon the question in the QA box, I can respond. Our federal nutrition program focuses on 1,000 days plus approach. We will be addressing the anemia in the adolescent girls also, whether in school or out of schools, and working with the other departments to for communication and awareness for better nutrition of the adolescent girls. Secondly, we will be also tackling the maternal malnutrition. I mean, after the first registration of the pregnant lady, if the mother is malnourished, she would be provided SNF to tackle malnutrition, and this would continue till 6 months of age. So this in utero or the pre 6 months period would be covered through this intervention.
Okay, all right, thank you. There's a question from Christine who's asking that with the large number of LHWs in the preventive side, focusing on IYCF messaging, so do you see that having them involved would have an impact in bringing these levels down?
They have been involved for IYCF messaging, but the issue was that Pakistan has a huge burden of food insecurity also. So just IYCF messaging would not work until and unless we also address that area. But now, as very recently we have started involving them in screening and management of wasting, definitely this would improve not only the coverage overall, but the outcome of the coverage in the country. Yeah, you are muted. Yeah, we cannot hear you. I mean, I'm sorry, Jay, I could not hear you. Your voice is not. Are you muted? Jay, can you hear me?
Hi, I think there's a problem with the audio for Jai. So can I ask you some questions, Doctor?
Yes, ma'am. Sure.
Okay. Hi, Jai, are you back with us? Do you want me to take over or are you doing okay?
No,
okay, I'm gonna go ahead and ask some questions. I'm just looking to see if there's anything interesting. With the large number of lady health workers in the prevention side focusing on IYCF messaging in the communities, is there something you're able to do to use that sort of platform to bring down levels of wasting?
Yes, Erin, I have responded to that question, and I think with the use of these large number of health workers, not only the screening would improve, which we are missing at present, but also the coverage of wasting management would also improve markedly. And there is another question about non-milk powder formula on production. At present, we are still using the milk-based formula. I mean, instead of peanut paste, local chickpea is being used for RUSF being produced. But for RUTF, we are still importing peanut. So the composition is almost still the same. But efforts are on by some of the local NGOs and other partners to develop alternate recipes for local production.
Okay, I think then Jai, can we hear you? Can you try again? No, okay. I think then maybe, Doctor, you've answered all the questions. So what we might do at this time is ask everyone to go back to the agenda and information, and what you'll be able to find there is the South Asia case study. So the presenters were not able to be with us live today, but we did pre-record the South Asia case study, which is a synopsis of the UNICEF ENN report on wasting in South Asia. So I invite you now to find that session in the agendas and information, to watch that video, and you can still comment and drop questions in the Q&A, and Tram from UNICEF said she would come on tomorrow and try to answer all your questions. So I'd really like to thank Jai. I'm really sorry about your internet connection. I'm really happy that you're able to join us. And of course, Dr. Khawaja, thank you so much for being with us today. We really appreciate it. And after you've watched the video of South Asia, there's a small break, and then please join us for the panel discussion starting at 2 GMT. Thank you very much, everyone.